Welcome to our live webcast, Beyond Standard of Care Treatment for Light Chain AL Amyloidosis. Promise of Tomorrow. Thank you for joining us. My name is Jacob, and I'll be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. On the right-hand side of the screen, you will see the text chat window. There's a large window which holds all of your sent messages. A smaller text box at the bottom where you'll type in your questions. Send a question, click in the text box, type your text, and when finished, click the send button. All questions you submit are only seen by today's presenters, and your questions will be responded to in the order in which they were received and be addressed at the end of the presentation. We are joined today by our speaker, Dr. Heather Landau, who is the hematologist, oncologist, and the director of the amyloid program at Memorial Sloan Kettering Cancer Center, focused on increasing access to novel, effective therapies in AL amyloidosis, and has investigated drugs at all stages of development. She has conducted multiple investigator-initiated clinical trials exploring novel agents and approaches, including consolidation and maintenance strategies in high-risk patients. She led the development of MSK's outpatient transplant service and is studying innovative ways to optimize high-dose therapy and transplant care. Pharmacokinetically dosed conditioning and the potential to truly personalize high-dose therapy. Dr. Landau has shown that delivering transplant care at home is safe and improves the quality of life and satisfaction of patients and caregivers.
Thank you for this opportunity to present to you Beyond Standard of Care Treatment for Light Chain Amyloidosis, the Promise of Tomorrow. The objectives are shown here, and they are to describe standard approach to treatment of AL amyloidosis, including the rationale to incorporate immunotherapy, to discuss how the treatment landscape has changed based on recent advances, describe novel immunotherapies and their potential role in AL amyloidosis, as well as reviewing other therapies being investigated, including those that directly target amyloid. Light chain amyloidosis is a complex disease characterized by the production of light chains by bone marrow plasma cells that misfold and deposit in critical organs. These pathologic plasma cells make a monoclonal protein, and a monoclonal protein means a protein of one type. So this is a disease-causing plasma cell, and it proliferates, and only one type. Typically, we have kappas and lambdas, but if it's just a single kappa or a lambda plasma cell that's proliferating, it can make antibodies, and these are antibodies. That's the normal function of plasma cells, to make antibodies because they're infection-fighting cells. And this is the heavy chain portion of the antibody, and this is the light chain portion of the antibody, and it's this light chain that's pathologic and misfolds into this substance called amyloid. And this monoclonal light chain is measured by an assay called the serum free light chain assay, and it's these amyloid fibrils that then deposit in various critical organs. So this is how we treat the disease. We target the pathologic plasma cell, which is the factory producing the amyloid. And here I show standard plasma cell-directed therapies, and the goal is to eliminate the pathologic plasma cell, which can reduce the circulating light chain, and we measure. That's how we measure the hematologic response, by the reduction of circulating free light chains by that free light chain assay. And once we control the toxic light chains, involved organs can improve, and we measure those by organ biomarkers. Patients who achieve both a hematologic and organ response have the highest likelihood of long-term survival. Again, if you have a hematologic response but not an organ response, you also have a good likelihood of surviving, but patients who do not do well are those who don't achieve a hematologic response. So the first goal of therapy is to get a hematologic response, and patients who get a deeper hematologic response have a higher likelihood of getting an organ response. And again, patients who get both a heme and an organ response have longer survival. The first immunotherapy in AL amyloidosis that was studied is daratumumab. Prior to daratumumab, all of the treatment that were standard of care chemotherapies for amyloidosis were borrowed from those used to treat the related plasma cell disorder, multiple myeloma. Daratumumab is an antibody against CD38, which is a plasma cell marker, and it was shown to have significant activity against pathologic plasma cells first in multiple myeloma and then in AL amyloidosis. So here I show the design of the Andromeda trial, which was a randomized trial where patients who were newly diagnosed with AL amyloidosis were randomized to standard of care chemotherapy, meaning VCD or bortezomib, Velcade, Cytoxan, and dexamethasone, with or without daratumumab, so daratumumab plus VCD or VCD alone, for 6 cycles, followed by, in the daratumumab-containing arm, daratumumab monthly for maintenance for a total of 24 cycles. The primary endpoint was in the trial is complete hematologic response, because again, that is our first goal of therapy, to get a hematologic response, with secondary endpoints shown here. And here are the results from the trial. And amongst almost 400 patients that were randomized internationally, we found that the patients who were in the daratumumab arm had almost a tripling of the complete hematologic response rate, 53% versus 18%, and that translated into a doubling of the cardiac response rate as well as the renal response rate. There's not long-term data to suggest overall survival benefit just yet, but patients, this was a real improvement in patient care. So overall, among newly diagnosed patients with light chain amyloidosis, the addition of daratumumab to VCD led to higher frequencies of hematologic complete response, and survival free from this was a secondary endpoint, major organ deterioration or hematologic progression. So Dara-VCD in 2021 became the first and only FDA-approved drug regimen for AL amyloidosis. And now for almost all newly diagnosed patients with AL amyloidosis, this has become the standard of care. The implications of the Andromeda trial is that Dara-VCD, as mentioned, is used as the initial therapy for almost all patients. And when this was looked at in a longer-term follow-up, the hematologic CR over time in the Dara-VCD arm, again, these patients continued to get Dara monthly after the initial 6 cycles, continues to rise and is 59% versus 19% in a subsequent publication. And that hematologic CR rate is similar to a CR rate that we see with stem cell transplant. And now, because of that, the role of stem cell transplant is being questioned. And there are 2 schools of thought here. Dara-VCD clearly increases the CR rate and results in organ improvement. And some folks would say that that would render more candidates eligible for stem cell transplant because patients are getting better and are more eligible for stem cell transplant if they improve. However, the other is also possibly true, that DARA-VCD increases the CR rate and organ improvement, and it may limit the need to do a stem cell transplant in patients who get less than an optimal response, and actually may limit the amount of stem cell transplants that we do. And so in order to figure out what the benefit is of transplant, now that we have this very effective therapy, there will be an upcoming randomized trial in the cooperative group, SWOG, studying upfront DARA-VCD induction, followed by stem cell with patients randomized to either stem cell transplant or DARA-VCD consolidation and daratumumab maintenance. And so we can understand what the benefit of transplant is now that we have very effective initial therapy. So while there is a clear standard of care for treatment of AL amyloidosis in the upfront setting, patients who are relapsed and refractory can be a bit more challenging. First of all, there's no FDA-approved drugs for this indication, and there's no real studies to guide us. However, we can use, this is a panoply of drugs that have activity and have been approved for multiple myeloma. And again, we borrow drugs from the related plasma cell condition multiple myeloma because they have activity against plasma cells. And not only can previously effective drugs such as bortezomib, Cytoxan, and daratumumab, if they were effective in the upfront setting, be reused, but many of these drugs that have activity in multiple myeloma also have activity in amyloidosis. However, toxicity in patients with AL amyloidosis can be quite limiting. However, I'm excited to share that now there has been an explosion of new drugs and many with novel mechanisms of action, that some of which have really been revolutionary for patients with multiple myeloma, and I believe they will be equally beneficial for patients with AL amyloidosis, and that's why I was excited to give this talk today. So starting with targeted therapy for AL amyloidosis, about 50% of patients with AL amyloidosis have the cytogenetic abnormality in their pathologic plasma cells, translocation 1114, and that renders these plasma cells uniquely responsive to a particular drug, venetoclax, a class of drugs, the BCL2 inhibitor, but the one that has been studied most is venetoclax. And there's been several retrospective reports of patients who were treated with this drug, and just to pick one, amongst 27 patients with relapse refractory disease, almost 80% of patients who were given venetoclax responded, and you can see that these were even very CRs and VGPRs, which are good deep responses. And this drug is very well tolerated, and now several clinical trials are ongoing and or planned. And I would say that venetoclax is a reasonable second-line treatment for patients with translocation 1114, and I use it routinely in my practice. Immunotherapy for plasma cell disorders are really the new frontier. Not only are there several different categories of drugs, but there are also several different potential targets. The single drug that has been approved for AL amyloidosis in this category is daratumumab, shown here. It's a monoclonal antibody. However, we now have antibody-drug conjugates, bispecific antibodies, and CAR T cells that have been approved for multiple myeloma and are all are going to be studied in AL amyloidosis. So why CAR T cells? This has really been a groundbreaking approach to the treatment of several hematologic malignancies, and the impressive efficacy of the B cell maturation antigen targeting CAR T cells, or BCMA targeted CAR T cells, has led to the FDA approval of 2 products for the treatment of relapsed refractory multiple myeloma based on these response rates, with overall response rates up to 98% and CRs up to 82%. And again, I remind you that Andromeda in the upfront setting showed that the addition of daratumumab to Velcade, Cytoxan, and dexamethasone led to a CR rate in the 53 to 59% range. So these are quite active drugs. And this is in relapsed refractory myeloma. We also know that BCMA is expressed on the surface of amyloidogenic plasma cells, and is also retained at relapse. So how CAR T cells work: blood drawn from patients are used to extract T lymphocytes, a certain type of white cell. These are the body's natural disease destroyer cells. And then these T cells are genetically engineered in a laboratory by introducing proteins called chimeric antigen receptors. These are introduced into the T cells, and then these are multiplied in the lab and then infused back into patients. And once in patients, these CAR T cells recognize and attach to the pathologic plasma cell and lead to plasma cell death. These are quite active drugs for patients with plasma cell diseases or heme malignancies more broadly, but they do have unique toxicity profiles, including something called cytokine release syndrome, immune effector cell neurotoxicity, or something we call ICANS, and also can put patients at risk for infections. So when we first started using them, these side effects were challenging to manage, and I would argue at this point we do have very effective ways of monitoring patients for these side effects and help and drugs and management strategies to prevent toxicity from these side effects. And the first report of a CAR T cell in a patient with AL amyloidosis was reported by the Spanish group. It was actually a patient who had multiple myeloma, presented with anemia and bone disease, and was treated with standard therapy, VRD, for 6 cycles, a transplant, consolidation, and had achieved a complete response, and went on maintenance therapy for about 19 months. Then she developed serologic progression and, again, anemia, a myeloma-defining feature, and went on to second-line therapy in 2017, achieving, again, a VGPR. But interestingly, the second time she relapsed with progression, she had no myeloma-defining end organ damage, but did develop low albumin and nonspecific proteinuria, which is common in patients with amyloidosis. And a fat pad biopsy and renal biopsy confirmed that she had amyloid deposition, in addition to relapse with 23% lambda-restricted plasma cells. And this is a very busy slide, but I show you her trajectory on This is her proteinuria, and on day 0, she gets this academic, meaning this engineered CAR T cell that was developed in the university in Spain. And when these were infused, you can see that this measures the amount of CAR T cells, and they expanded. And at that point, she got what we call grade 1 CRS with a fever, but didn't need any other intervention. It got better on its own. The cells expand and then they contract, and at the same time, you can see this is her serum M protein and this is her serum free light chain. And with the cells doing their job, these paraprotein numbers come down, and over time, 6 to 12 months, her protein that she was losing in her urine gets better. She has a bone marrow that no longer has any plasma cells. She did develop 2 notable infections, BK virus hemorrhagic cystitis, which was treated, and COVID pneumonia, both of which she recovered from. And ultimately, 3 years post-CAR T cells, she remains in what we call an MRD, or minimal residual disease negative, complete hematologic response, and her kidneys continued to recover. More recently, Moshe Gott from Hadassah Medical Center presented data on 5 patients with AL amyloidosis that were treated with a academically engineered CAR T cell against BCMA. This construct was structurally optimized to target plasma cell disease and developed to show optimal cytoreduction in mice. And then a phase 1 clinical trial was designed in particular in patients with multiple myeloma, but they allowed for inclusion of patients with light chain amyloidosis. So this was a dose escalation study where initial patients got a lower dose and then escalating doses, and in 3 different cohorts. And you can see here amongst the 3 different cohorts, there was 5 patients with AL amyloidosis that were treated. And Dr. Gott presented this at the International Symposium for Amyloidosis last fall and showed that among the 5 patients that had amyloidosis, they treated patients up to 82 years old. All of them had multiple organ involvement, including cardiac involvement with high NT-proBNP values and cardiac stage 3A in 3 out of 5 patients. They did all have reasonable performance status. They were given different doses of CAR T cells, and 80% developed CRS, which is common with these drugs, as I said, but all were managed, and none of them developed ICANS or the neurotoxicity that we see. In terms of efficacy, 5 out of 5 patients, 100% of patients, achieved a complete hematologic response. They were all MRD negative, and amongst the 4 patients who were evaluable, all achieved an organ response, including significant reductions in NT-proBNP and proteinuria, as well as clinical improvement as indicated by the New York Heart Association class of heart failure change. So in all, this data shows that AL amyloidosis patients express sufficient BCMA for clinical targeting by CAR T cells. 5 patients were described, and they were able to endure CAR T cells with relative safety. Due to quick and deep light chain reduction, organ response was observed very quickly. And while this trial is ongoing and other trials specifically enrolling AL amyloidosis patients are planned, and this is a very exciting new strategy for our patients moving forward. Other immunotherapeutic approaches include antibody-drug conjugates. The drug that was approved for multiple myeloma, belantamab mafodotin, is an antibody-drug conjugate directed against BCMA. So here is this antibody-drug conjugate. This is the antibody. This is the drug. This antibody-drug conjugate binds onto BCMA on the pathologic plasma cell and delivers the cytotoxic payload in order to effectively get rid of the plasma cells. There's been few retrospective series reported and one prospective trial underway in AL amyloidosis. And while this is a small data set amongst 11 patients who were treated with this drug, the overall response rate was in the 60 range and with 55% achieving optimal or VGPR or CR or better. This too has unique toxicities with ocular or eye toxicity in up to 80% of patients that manifests mostly as blurred vision. The good news is, while this is a very irritating side effect, once you stop the drug, it is ultimately reversible. Other immunotherapeutic approaches include bispecific antibodies, and here I show a schematic. This is again an antibody engineered with one arm to target a molecule on the pathologic plasma cell and the other one to attach to a T cell. And there are different types of targets on the plasma cell, but again, we've been talking about BCMA, so this bispecific antibody attaches to the BCMA on the plasma cell and the CD3 molecule on the T cell, and it's one of these T cell redirecting therapy. So then it brings the T cell closer to the myeloma cell or the plasma cell and leads to pathologic plasma cell death. There are now, very exciting, in the last less than 12 months, 3 new bispecific antibodies approved for multiple myeloma, including teclistamab, elranatamab, and talquetamab, which has a different target than BCMA. All of these drugs have are significantly active with response rates in the 50 to 60% range and CR rates in the 30 to 40% range. These are similar to CAR T cells in their toxicity profile. Again, these T cell redirecting therapies, which are this bispecific antibodies and CAR T cells are in that class of drugs. They have this CRS, ICANS, and the risk of infection because you're redirecting your T cells. And so those complications have to be managed. And interesting and excitingly, clinical trials in AL amyloidosis using BCMA-directed bispecific antibodies, including teclistamab, elranatamab, an AbbVie product, are in development, and more are to come. There's also amyloid-directed therapies. We know that our standard of care treatment for AL amyloidosis targets pathologic plasma cells, but it doesn't address the resident amyloid in organs or tissues. So there are drugs in development to facilitate removal of amyloid fibrils, and I show you 3 here. KAL-101 or anselamimab is an antibody that binds to an epitope on misfolded light chains and amyloid fibrils. The initial data in patients with advanced cardiac disease showed about 80% of patients had a cardiac response, and there are 2 phase 3 trials underway in these patients with advanced cardiac disease who often have limited treatment options. Bertamimab is a similar antibody, again cross-reacts with misfolded light chains and amyloid fibrils. This was called NEOD-001 and now has the name bertamimab. The initial phase 1/2 data was very promising and suggested 57% of cardiac patients and 80% of renal patients responded. This led to 2 larger trials that were unfortunately terminated early for futility. However, a retrospective analysis of these data showed that there was a possible benefit in, again, our most advanced patients, those with Mayo Stage 4 disease, and a phase 3 trial in this population with this agent is also ongoing. Lastly, AT03 or AT02 is a similar antibody that binds to amyloid fibrils. Again, all of these, when they bind to the amyloid in tissues, they incite the patient's own immune system to clear the amyloid deposits, and this particular drug is being studied in Australia. There's also a novel approach to treating light chain amyloidosis. As we know, the disease starts with pathologic plasma cells that secrete light chains, and if these were normal light chains or non-toxic light chains, they'd be excreted by the kidney. However, pathologic light chains from pathologic plasma cells can unfold and then misfold and then aggregate into these amyloid fibrils, or just by virtue of being misfolded can cause cytotoxicity and lead to cell death. However, if there's a new treatment strategy with a stabilizer molecule, and if we can prevent these pathologic light chains from unfolding, it is plausible that these light chains will be excreted by the kidney and prevent this amyloid formation and the associated cell death. So I want to end with an inspiring journey. I'm telling you about patient RS. This was a gentleman who was 49 when he presented with weight loss and early satiety in 1997. At that time, he was just watching his daughter graduate from high school. But the subsequent spring, he was finally, after having several months of symptoms, diagnosed with AL amyloidosis involving the GI tract and the liver, and had 15% kappa-restricted plasma cells in his bone marrow. And at that time, in 1998, these are the survival curves, and I would say patients with heart disease lived only about 5 months, and even patients with other organ involvement lived at most 15 to 30 months. Then it was at that time that the first stem cell transplants were being studied in Boston, and he was eligible for this phase. Bone marrow was normal, his biomarkers were normal, and his liver shrank, and he became a well person. He went to visit his daughter at college for Parents' Weekend and looks entirely well. He continued to live well, but presented to MSK in 2002 when the serum free light chain assay was developed, and he actually was self-referred for this free light chain assay to see the extent of his disease, because we never had a very effective serum marker for amyloidosis before the free light chain assay. And at that time, his blood was tested, and he was found to have elevated light chains, but at the same time, he was a well person, and nothing was thought needed to be done. He continued to be well until several years later when he developed a more myeloma-like picture with lytic disease and anemia and abnormal creatinine, and then ultimately ended up going through multiple rounds of therapies that were approved for multiple myeloma, which all helped but were associated with toxicity. And every few years, he was treated with the next best drug, first thalidomide, and then bortezomib, and then carfilzomib, and then daratumumab, and then combinations with daratumumab, and then elotuzumab, and ixazomib, and pomalidomide, and multiple agents throughout the years. And in 2022, he again presented with more amyloid-related symptoms, weight loss, early satiety, in addition to his bone lesions. And that was when the first CAR T cell was approved. The second CAR T cell was approved. Abecma was approved in 2021, and Carvykti was approved in 2022. Although the availability of CAR T cells has been and continues to be a little bit of a conundrum. However, by late last year, he underwent apheresis for CAR T cells, got collected, and then he was bridged with venetoclax and radiation, and ultimately received CAR T cells in February of this year. And this is his daughter, now a grown woman, at his bedside on the day that he received his cells. And for the first time since 2002, since his kappa light chain was detected by that serum free light chain assay, when that assay was available, his kappa light chain was normal for the first time after his CAR T cell. His PET scan, which had FDG avid uptake, also normalized, and he is now living 25 years later after his initial transplant with the advent of all these drugs to see not only his daughter but his granddaughter able to grow up. And I know this story because my daughter is friends with his granddaughter, and that's how I met this gentleman who's had an incredible and inspiring course. So in conclusion, a standard approach to the treatment of AL amyloidosis now incorporates immunotherapy, namely the monoclonal antibody daratumumab, and has really changed the treatment paradigm. Whether this is going to increase or decrease the use of stem cell transplant in the upfront setting is being studied. Other immunotherapeutic approaches, including antibody-drug conjugates, CAR T cells, and likely bispecific antibodies directed against BCMA, appear to have promising efficacy in AL amyloidosis, and studies in the salvage setting are ongoing and planned. These agents have unique toxicities, and we need to get experience managing them, not only in the myeloma patients, but now in the AL amyloidosis patients. Novel therapies, including those that directly target amyloid deposits or stabilize light chains, have the potential to reduce or improve organ dysfunction from amyloidosis. And here are my final thoughts. Nothing replaces the importance of early diagnosis. I can't have a lecture without saying that, because the longer patients go without a diagnosis, the more compromised their organs are, and the harder it is to treat. So really, in my opinion, nothing replaces the importance of early diagnosis, and participation in clinical trials is really essential to get any of these therapies to our patients. And with that, I think the future is bright ahead, and I'm happy to take any questions.
All right, perfect. Thank you for the wonderful presentation. Again, if you do have any questions, feel free to go ahead and type those questions into the Q&A pod there on the right-hand side of your screen, and I'll turn it over to Dr. Landau now to answer any questions we have.
So we have a few questions already in the chat. I'll just read them through. I would say that any questions that are particularly specific to an individual's case, I may skip over, and those questions can be directed to the Amyloid Foundation email, and they can send them to me that way. So the first question is, what's the best way to gauge disease progression? And that's actually a tough question because everybody's paraprotein is different. Everybody's free light chain is different, and oftentimes we see the light chains go up incrementally with some evidence of organ progression. Other times we see the light chains go up incrementally with no evidence of organ progression, and sometimes we see organs progress in the absence of increasing light chains, and that's always a conundrum whether or not that's true disease progression or that's the natural history of organs that are infiltrated with amyloid. So disease progression is definitely not as well studied as one would hope. We don't have any validated criteria for hematologic progression, but it really takes a thoughtful practitioner to make a decision of when to retreat a patient. And if you ask several different experts, there'll be different answers to that question. But you should always report any new symptoms to your patient, to your doctor, and they should be able to evaluate you in that setting. Will slides be made available after the event? I believe so, on the website. A screen with multiple new drugs to treat. I showed a screen with multiple new drugs to treat AL amyloidosis. How cost effective or affordable will these drugs be? That is a great question. These are certainly CAR T cells, and bispecific antibodies are quite expensive novel agents, and that's why it's so important to participate in clinical trials and get these drugs approved for this indication, or else the chances of getting drugs when they're super costly and there's no indication is smaller and smaller. When these drugs if they are approved for this indication, it would be based on efficacy. And again, when you have a disease with very few available agents or even effective agents, hopefully it will be welcome. In your practice, what drugs, if any, do you combine with venetoclax? Venetoclax has been studied with several different partners in amyloidosis. The best partners seem to be daratumumab and bortezomib. Because those are the drugs that have significant efficacy and are tolerable in this disease. In multiple myeloma, again, multiple drugs have been and are undergoing testing with venetoclax, so that data can be extrapolated, except again, worried about the toxicity with any other agent. But there is single agent activity with venetoclax alone. Regarding the fibril removal drugs that are in stage 2-3, when do you see an FDA approval? That is a great question. I think the most mature data is from the CAL 101 trial in cardiac stage 3A, but that has only recently been fully accrued, and we're waiting on events to happen to get the data. So it'll depend if the data shows a good enough signal in that disease category for whether or not FDA will approve the drug. But we're a while away, unfortunately. So sit tight, but I think if there is a signal of efficacy, it will be approved. Have there been any studies of drugs to facilitate removal of amyloid fibrils in persons with organ involvement, heart and kidney, but not told they are in stage 3 for cardiac and have already experienced improved kidney function? Heart is stiff, has been impacted. I think this is a pretty individual question. I can say that, again, NEOD-001 was initially studied in both patients with heart and kidney, but not necessarily had heart and kidney. And there was some data in that setting that there was renal improvement. Again, the initial data was very difficult to interpret because the criteria for entering the trial were such that everyone had to be in a good hematologic response going in, so the organ improvement was difficult to attribute to the fibril removing agent versus the natural history of the disease when one achieves a good hematologic remission. New treatment for wild-type amyloidosis. There are several being. There are several drugs that are being studied and some actually approved. Tafamidis is the main treatment. Again, I talked a little bit about light chain stabilizer, the potential for a light chain stabilizer drug to work in patients with light chain amyloidosis, and that is really gives credence to the tafamidis, which is a drug that was developed to stabilize TTR molecules such that they can't misfold into amyloidosis, and that has been a proven strategy, at least in that disease. What do you think about the drug Vyndamax for light chain amyloidosis? Again, for patients who have the translocation 1114, I think it's really a welcome addition. Again, not approved for this condition, not even approved for multiple myeloma with translocation 1114, but has been used off-label with very good results. How does one volunteer for a clinical trial? That is a great question. I think that you should ask your doctor if there are any, if your doctor is not participating in clinical trials, if there are any centers in proximity to you, or ask the Amyloid Foundation or ask the Amyloid Research Consortium, have long lists of what amyloid trials are going on. And if you're relapsed or if you're newly diagnosed, they can probably direct you to what centers have ongoing trials in the right space. Not everybody will be eligible for clinical trials based on where you are in your disease. If you're responding to whatever treatment that you're receiving, it's unlikely that you'll be eligible for a clinical trial. Eligibility criteria are often an issue in terms of getting patients onto trial, but certainly if you are eligible for a clinical trial with a novel agent or even observational trial, it just gives us more data to push the field forward. In addition to stem cells and new medications evolving, has any study been done regarding diet to improve, to improve this condition? That is a very interesting question, and I can say my colleague Urvi Shaw, who has been studying plant-based diets in patients with plasma cell precursor disease, namely monoclonopathy of undetermined significance, which is a precursor to amyloidosis, as well as smoldering myeloma, where patients at our center are now getting plant-based diets because there's an indication that a plant-based diet can have immune-relevant effects that change the trajectory of your immune complement such that it can halt progression of underlying plasma cell disorder. Again, this is not ready for prime time, but it is being studied because there is at least a signal that this could be a strategy, probably not for all comers, but at least for some patients, it may make a difference. But the jury is still out on that. So, but plant-based diet is definitely being studied in this space. Not necessarily directly for amyloidosis, but for precursor disease, which could lead to amyloidosis. How durable is daratumumab proving to be? I think we don't know the answer to that. I think in many patients this is quite durable. The median time to progression, meaning with over 2 years of follow-up, 80% of patients still remain in remission. So there's not a known median, meaning when 50% of the patients will progress on this drug. So I think that there is good durability. We don't have the long-term data, however, long enough follow-up for the Andromeda study to say how long the durability will be. What are the steps to get included in clinical trials? Again, identifying a clinical trial that you may be eligible for and undergoing screening. which often means blood work or bone marrow or organ assessments to determine if you are eligible for clinical trials. Are there any studies to vacuum residual amyloid fibrils from affected organs after stem cell transplant? So there's not, I think you mean the amyloid, the drugs that are amyloid directed. These are antibodies that bind to the amyloid deposits and incite your own immune system, meaning macrophages, to not vacuum but gobble up the amyloid and get rid of it. And that's how these drugs are thought to work. After transplant, the first NEOD-001 trial was done in that space, but since that time, because it's proven so difficult to interpret the results when somebody's already had an effective therapy, these drugs are now being studied in the upfront setting. So at this time, these drugs aren't being studied in that space. If they prove effective, then I would suspect that studies in that space would be certainly forthcoming. Do these therapies equally attack normal plasma cells as well as disease plasma cells? That is a great question, and many of our therapies, including the CD38 antibodies, and yes, CAR T cells can have effects on normal plasma cells, and that's why infections become a significant issue. Our normal plasma cells are plasma cells are infection-fighting cells and responsible for keeping folks healthy after an infection and getting rid of it. And if you get rid of both the bad and the good plasma cells, there's often immune dysregulation or immunosuppression, such that patients are more susceptible to infections. What therapy is being evaluated for relapse AL with the digestive tract involvement? I don't think we have any specific trials in that space yet, but again, I think after if and when the amyloid-directed agents prove effective and are available, I think that they will probably be used more readily in different patient populations. Whether or not there's going to be specific trials for patients with digestive tract involvement is I'm not aware. The issue with patients with digestive tract involvement is that everybody's symptoms are quite different and there's no objective measure of response. And when pharmaceutical companies are studying their drugs in patients, that's why renal and cardiac are not only are they the most frequent organs that are involved with amyloid, but they also have objective response criteria so that both investigators, patients, and the FDA can understand the response in an objective way in order to consider them for FDA approval. Have you heard of anyone extrapolating a clonoSEQ result to an estimated total body tumor burden and extrapolating treatment performance to guide consolidation beyond MRD negativity to a theorized total burden near zero? I'm not exactly sure what you mean by that, but I think that MRD by several different methods is being studied in amyloidosis, both clonoSEQ, flow cytometry, and mass spectrometry assays are being used in this way. I think that to date, I would say that most plasma cell disorders are not considered curable. But if we can consolidate and get to MRD negative, where we can either have no circulating light chain detection or no clonal plasma cell detection, I suspect that patients will have the capacity to improve their organ function and live longer and have extended overall survival. But that has yet to be proven, and on what assays are available and their level of sensitivity. As a Canadian AL amyloidosis patient, is there an opportunity to participate in clinical trials? I believe so, but I can't say for sure. It may depend on insurance coverage, because not all medical care associated with a clinical trial is covered by the clinical trial. I'm trying to see if there's any other. How is it determined if organ damage is limited to a single organ or multiple organs? Are there specific tests, or can it only be done through biopsies of various organs? I would say there are certain organs have biomarkers that we can follow, namely the NT-proBNP, BNP or troponin when cardiac disease is suspected, proteinuria in patients with kidney involvement. Other organs such as the GI tract often require biopsy. You can suspect it when patients have symptoms, but not necessarily can prove that anybody has a particular organ involvement unless you do a biopsy. That is the most specific way to determine that an organ is involved. Is Cytoxan part of standard treatment for AL amyloidosis? Yes, that was part of the CyBOR-D regimen. So that combination is cytoxin or cyclophosphamide, Velcade or bortezomib, and dexamethasone. And that was what was combined daratumumab in the Andromeda study. Are there any trials being developed for amyloid removal in the heme-CR stable patients? Again, this was the way that the initial NEOD-001 trial was designed, that patients who had already achieved heme PR or CR were enrolled in the trial. And the problem with that trial design is that unless it's randomized, it's difficult to discern what effect of the amyloid binding drug versus whether or not patients are getting better in the setting of achieving a hematologic CR. We tried to enroll patients who had only stable or deteriorating organ function on that initial study, but it still was very difficult to definitively say what was causing the improvement. In a randomized study, that should be able to be answered, but no trial like that is currently available. I do suspect if these drugs prove effective that more and more trials will be forthcoming. Somebody asks about long-term use, about Kyprolis and Pomalyst, and I think, again, as long as you're tolerating the drugs and toxicities are being monitored, patients can stay on these drugs for quite some time. If you have achieved a complete hematologic response, then often we give you a treatment break. Are there new insights on where or how AL amyloidosis comes about or originates? That is a great question. I think it's probably a balancing act between the immune system, some inciting event. Again, this is unknown. And the milieu in which these plasma cells have are proliferating, and it's really not clear how it comes about or originates. And if we knew that, we would be much better off at preventing it. But in AL amyloidosis, it probably has something to do with an immune stimulus and a balance between that and the genetics and the microenvironment of the patient, the host, or the patient itself. For cases in which the initial treatment causes light chains to return to normal levels, how long should it take for protein levels in the urine to decrease? That's a great question, but I would say that I tell my patients that even if we achieved a complete hematologic response, it takes months to years for the protein in the urine to get better. Yeah, it is not a sprint, it's more of a marathon. And patience is definitely a virtue, but it could really take months to years. Do the early signs include high heart rate, fatigue, bilateral carpal tunnel, any other symptoms to be aware of? I think everybody's very different, and symptoms are often very nonspecific. which is why patients often go undiagnosed despite feeling unwell, but it's really nonspecific. You just feel unwell, or you have weight loss, or short of breath. Bilateral carpal tunnel syndrome is associated with this condition. So certainly in that setting, if you were to feel unwell, somebody has to a suspicion, but it doesn't necessarily mean you always have amyloidosis. Would precede diagnosis for several years. It's rare. That too is a great question. It is, but I think that with more awareness, I think it's becoming less rare, but it's still compared to other it's 20% as common as multiple myeloma, and multiple myeloma is a fraction of the prevalence as something like breast cancer or colon cancer or lung cancer or prostate cancer. So it's still rare, but I usually say it's rare-ish because it's probably a lot more prevalent than we even know. But with increasing awareness, I do think that that's the most important thing, to get patients diagnosed early, and it will become possibly less rare. From a high level, is there a case to be made that these new immunotherapeutics should be used before the standard treatment, or is it still that standard treatment should always be done first? We really don't have that answer. I think the good news is that our standard treatment, the Andromeda trial, has shown that the CR rate in the upfront setting is 60%. That's really comparable to the best response that we had with stem cell transplant, and now stem cell transplant is being compared to upfront treatment with Dara-CyBorD or Dara-VCD. Whether or not these new immunotherapeutics, which have even higher response rates, are going to supplant both these strategies is unknown, and we have to also be cognizant of the unique toxicities in this from these agents. So the infection risk is very real, and the CRS and the ICANS, fortunately, has become very manageable. But there could be long-term cytopenias as well, and these are all things that, again, with more experience, hopefully will become more manageable, but we have a good handle on how to manage patients on Dara-VCD, and again, amyloid patients getting these drugs. Really, there's been very few. So I think we're a ways away from moving it to the upfront setting till we prove that it's safe and effective in this population, but I'm very hopeful. Is there new medical equipment for the heart and kidneys to show where the amyloid is? There are imaging studies, imaging agents being developed, but I wouldn't say that they're ready for prime time yet. With patient RS, could you please elaborate on bridge with venetoclax RT? in the penultimate stage? Yeah, so that's a good question, because what happens with CAR T cells is it's a process. So in contrast to daratumumab, which is a drug that's available off the shelf, your doctor says they want to give you daratumumab, and they order it, and the drug comes. CAR T cells are engineered cells. So what happens is you first have to be leukapheresed. So your white cells are collected, your T cells are collected, then they have to be shipped off and engineered to have the chimeric antigen receptor placed. And that often is a process that takes weeks. So in patients, particularly in multiple myeloma patients who can have more commonly rapidly progressing disease, patients will have to be managed with some what we call bridging therapy or some plasma cell directed therapy while they await the availability of the CAR T cells. Is it understood why young people with no past medical history develop AL amyloidosis? Less than 30 years old, is it genetics, environmental factors? Have any factors been linked to etiology? Again, I wish I had an answer to this question. I propose that it's possibly an insight of the immune system on balance with genetics and the milieu that these plasma cells are developing in, but I really can't say that I have a good understanding, or we as a field have a good understanding of the origins of AL amyloidosis. Are there dietary guidelines to help alleviate protein production? Unfortunately, I wish there was a magic bullet to say that if you do this, this, and the to say that if you were to follow a certain specific diet, you would prevent the protein loss. I don't think we're first studying whether a plant-based diet can manipulate the immune system to make it more effective to control pathologic plasma cells, but I don't think we're there yet. And whether or not a certain diet can prevent or reduce proteinuria, I don't think we're there yet either. Is venetoclax approved in AL amyloidosis? No, it certainly isn't. The only approved drug regimen that for AL amyloidosis at this time is daratumumab plus VCD. If one organ is affected by amyloidosis, can or does the disease move to another organ? If so, why, when, etc.? Everybody's disease is quite different, and some patients have only single organ disease. Some patients have multiple organs involved with amyloidosis. Some start with one organ and then eventually do develop other organs. Most patients who start with one organ, it stays in one organ, but not always. So it really depends on the progression and why that happens. Again, I wish I could say I had a good understanding of why. There is some data for the complement of light chain that the pathologic plasma cell produces, the genetics, the genomics, to have a propensity to certain organs. But really, how that happens in a single individual is very difficult to know. you think bertemimab can meaningfully improve on CyBorD in stage 4 cardiac patients? I don't know. That's why it's being studied. I think that there was at least enough promising data that it is being studied. So the trial will tell us. How is AL amyloidosis staging determined? Mostly because cardiac disease is really the biggest driver of morbidity and mortality. We have cardiac staging system, which was first developed in 2004 and refined in 2012 to include not only the cardiac biomarkers, predominantly cardiac biomarker staging systems, actually now 3 because there's a European modification. Renal disease can also be staged and can predict not overall survival, but renal survival, meaning time to end stage renal disease or the need for renal replacement therapy or dialysis. What can a person on their own try and help removal of amyloid deposits? Vitamin C. I don't think there's any data, unfortunately, for vitamin C to assist in removal of amyloid deposits. If we knew what any individual could do about it, it would be, welcome information, but I don't think that we have that data. How much will AI assist earlier detection by primary care? That is a great question. And I think there's at least some data to suggest that AI interpretation, meaning artificial intelligence interpretation of ECG data, can potentially be effective at identifying patients with amyloidosis. That is really very exciting new development and currently being studied. I wouldn't say that that's ready for prime time either, but there seems to be some data in that way to suggest that a certain pattern on an ECG could be suggestive of amyloidosis, and again, that would be something that that a primary care physician could consider. Again, they have to first think about amyloid to consider using AI in this way. So awareness of the disease is really most important. But there may be AI ECG data coming out to suggest earlier diagnosis and other data like cardiac biomarkers and relay chain trajectories are likely to be studied. Is neuropathy a side effect of amyloidosis itself or the drug treatment? Will it dissipate at some point? Oftentimes it is associated with the disease itself, but on the other hand, Velcade is a known cause of neuropathy, and often, even in the setting of a complete hematologic response, it can cause neuropathy, which is probably related to the disease and not related to the treatment and not related to the disease. It often gets better over time, but it too takes months to years, and sometimes it doesn't reverse completely, both disease-related neuropathy and treatment-related neuropathy. But at least the painful aspects of neuropathy can be managed with medications. Any research on facilitating removal of amyloid fibril from nerves? Again, this is a difficult space to study drugs because there's no objective response rates, and it's very subjective, and that's why it's difficult to study drugs in this setting. Do you use IVIG to help patients get their immune system up? IVIG is indicated in patients with underlying plasma cell disorders if patients, not just by virtue of having suppressed immunoglobulin levels, but if they are subject to frequent or severe infections. That is in the current clinical landscape. However, with CAR T cells and bispecifics, where the risk of infection goes up, there is more liberal use and even mandated with the bispecific antibodies use of IVIG in the setting of low immunoglobulins, given the substantial risk of infection. What are the likely timeframes for someone on DARA to be moved to CAR T? It really depends on your response and the durability of the response. Most trials of amyloid removal drugs are for newly diagnosed patients. What about trials for patients with prior treatment and good hematologic response? I think I addressed that before, that it's difficult to interpret the results in this setting. That's why these drugs are now being moved into the upfront setting, where there's more objective response criteria. After treatment of AL amyloidosis with either a stem cell transplant or Darzalex, what is the average length of time before relapse or the disease potentially recurs? Again, we don't have the median time to progression in patients who are treated with upfront daratumumab. In the relapse setting, after 2 years, 80% of patients are still in remission with daratumumab. So we'll have to follow patients for longer to see what the median time to progression is. And the event-free survival after stem cell transplant is about 4 years, 3.5 to 4 years. But again, that means 50% of patients relapse before that time point and 50% after. So we do have long-term remitters from high-dose chemotherapy. And I'm hopeful that we'll have some long-term remitters with daratumumab up front as well. Do you currently treat high-risk multiple myeloma AL amyloidosis differently, such as deletion p53, gain 1q, or translocation 414? Cytogenetics at this time in AL amyloidosis don't necessarily don't necessarily dictate our treatment choice, with the exception of translocation 1114 for the use of venetoclax. Early detection of this disease depends on educating people and doctors what's being done by the medical profession to increase awareness of this disease. I would say a lot, but not enough. My colleagues and I had a grant to try to disseminate information through webinars in underrepresented areas where primary care physicians, to get to primary care physicians and subspecialists to try to facilitate diagnosis. I think that many other groups are doing similar things, trying to educate the community, but really that is a major issue. Other organizations such as Mackenzie's Mission is a group that is working with amyloid, train patients to really introduce the concept to doctors in training, both at the medical student and interns and resident levels, which I think will be quite helpful again. But if it's rare and you see these, hear about these conditions during medical school and then don't see it again for several years, it's hard to hold on to that knowledge. So continued medical education in this area is really essential. So the more people who can talk about amyloid, the more people who can spread the word, the more people who can miss a diagnosis and then be told that they missed the diagnosis, or more doctors that can have a patient with amyloid. Hopefully more physicians will think about it. So that's the first step to diagnosis.
It looks like we have time for one more question, and we'll go ahead and wrap up. All right.
Can you still
Yeah, go ahead.
Yeah, that's okay.
No, go ahead. It's okay.
Can you still expect kidneys to recover more function after 18 months on daratumumab? This is an interesting question because the proteinuria typically continues to improve over time, but when the renal function is impacted by amyloid, it is common that the renal function itself does not improve. So when the amyloid deposits in the glomeruli and leads to protein loss or proteinuria, when patients get into a hematologic remission, over time we do see the proteinuria improve. If the renal function, for whatever reason, whether there's vascular amyloid or a secondary insult, and the creatinine rises or the glomerular filtration rate decreases, that is often irreversible. So if the issue is kidney function and it's 18 months and nothing's budging, I wouldn't expect it to get better moving forward.
All right, perfect. Looks like that is all the time we have for today. On behalf of the Amyloidosis Foundation, I would like to thank you for your participation in today's event. This does conclude today's program. Thank you and have a great day.